All right, welcome to our last meeting. I was going to consider doing part like review, part like another journal club, but I was worried, this being the first time I've done all of them online, that I want to make sure everyone got it, right? So I decided to focus more on the review, at least this time, and just to see how everyone's kind of feeling about it, making sure people were watching along and at least like having some understanding of the material. This is where we can kind of like see, like, you just go, I didn't understand what the heck you're talking about, and that's great feedback. So any questions I can answer to begin with? You guys are awesome. So when you have to have the review, you can just, go, right? No? Okay, let's do some reviewing. Okay. So, you guys remember this lovely chart? Again, a lot of this stuff is kind of depressing. Like, epidemiology is not a very uplifting subject, unfortunately. However, they can get a lot of good information from this sort of chart here. So, the question being, what the heck is prevalence? So basically, a prevalence is you're looking at a snapshot in time. You're looking at the proportion of people within a given population that have the disease state or the risk factor, whatever it is you're looking at, that actually have that at that time, right? So for instance, if I was looking at a snapshot here and I was saying, okay, what's the prevalence of HIV that was being diagnosed, say at the beginning of 1990? Okay, how would you figure that out? What would that add up together? Remember, the dark gray bars are the proportion of people who got diagnosed but then died, or at least were dead at that time frame. They did that next year. And then the white bars are the people that were still alive.
The total number minus the white, or minus the black?
Yeah, so basically you end up taking up all these white bars here and just kind of adding all those up. So you can get, again, that's kind of a crude form. If you're looking at actual prevalence at the very end of the time frame, this would be all of the white bars added up together, right? It's kind of hard because, again, this is looking at the data kind of retrospectively. So, but yes, the prevalence at the very end of the time frame would be all the white bars added up together, okay? On the other hand, what would be like the incidence? How would you describe that? Yeah, new cases in a given time frame, right? So for instance, if I were to say what was the incidence of HIV in 1990, what would you say that is? The gray part, the white part, the whole bar? The whole bar, yeah, is all the incident cases that were diagnosed in that year, right? So incidence is kind of moving forward, new cases that are popping up. Prevalence is looking at a snapshot saying like, okay, this is the proportion of people that have a disease state or whatever I'm talking about, whatever my issue of concern is at that time frame. That make sense? Okay. You guys remember what like at a period prevalence is? Yeah, so over a time frame, so you see the number of prevalent cases during that period of time. You guys remember what that point incidence was? We talked about that as well. Remember that one graph that had like the different people, like some of them were getting healthier, some people were getting newly diagnosed, some people came into the study already having the disease, some people were leaving the study with the disease. I'm sorry, yeah, so again, that was misspoke there. So the point prevalence there, if you took just one time shot, then you can see how many lines were crossed essentially, and that gives you your point prevalence at that point, right? But the period incidence would be like the number of new cases that happen over that time frame, if it was 5 years, 10 years, whatever it happens to be, right? So kind of keep those definitions in mind, what the differences are between those features.
Is that the graph in which you drew a line down?
Yeah, so it was one where you had the people that began the study who already had the disease state, you had people who were leaving the study with the disease state, and some people were either dying or getting healthier, were not considered to have the disease state anymore at a certain period of time. Some people were being newly diagnosed. So again, look at that graph again and you'll kind of get an idea what we're talking about there.
Could you describe point prevalence again, please?
Yeah, so point prevalence, if you were saying like, okay, at a given point, we're going to look at, say, this day, what were the number of people that actually had the disease state of interest at that time frame? So again, looking at that other graph, which I'm sorry I didn't include that on here, if you were to draw a straight line down, that would be the number of lines you cross essentially, right? So the number of people that actually had the disease state at that period. So you lose the people that had already died from it, and you lose the people who may have been diagnosed later. But you're just looking at the prevalence at that one particular point.
Okay.
Right.
So then you just add up the white bars.
In this case, yeah, so if you were looking at the end of 1992, your point prevalence would be all the white bars that are still alive, presumably at that point.
On the exam, are you going to have graphs possibly?
I did not include any graphs actually, but the concepts were the important thing to grasp for this. Okay. So a lot of typing, not a lot of conjecture going on. So I'm assuming everyone's like, yeah, duh, this is easy. Okay, so going back, remember the Beings model? What is that? What is the Beings model? What's it a paradigm for? A paradigm, if you will. Okay, so different factors. So again, so would you say it's allocating public health resources? No, we wouldn't say that. Assessing the impact of herd immunity? No, that wouldn't be it. How about determining the role of specific policy on public health? Not really. Establishing the importance of social contacts? Nah. Evaluating etiologic factors in disease? Yeah, we could probably say that. So again, you'll see this. The answers will be highlighted on your slides as well in the next slide if you're looking at that. So you remember what the B stood for in beings? Good, biological factors. Good. How about the E? Environmental factors. So were you exposed to lead? Were you exposed to asbestos? You know, what type of workplace are you in? That's good things to consider. Have the I. Immunological. Good. So you can look at like vaccine status. You can look at immunodeficiency, different things like that. N. Nutrition. Perfect. How about G? Genetics, and then the S. Social, services, spiritual, things like that. Because again, remember we were looking at one thing, is looking at like Seventh-day Adventists, like they have a pretty healthy lifestyle, so perhaps that influences, their mortality, things like that. Several of these factors can go in together at the same, factor into one disease state. So for instance, when looking at lead exposure, one of the things you have to consider as well is, where do you find a lot of lead in buildings and things like that? In paint, yeah, so it's found a lot in paint. You know what, like newer buildings, older buildings? Older buildings, right? So you saw that, what type of environment the patient's in is really important. Were they living in an older building? Also, you have to look at their nutritional status, because lead, I don't know if anyone knows this, but it looks a lot like calcium in the body, right? The body can't tell the difference between lead and calcium, so that would stand to reason that lead ends up where in the body, especially in developing children. In the bones, yeah. So you can see lead lines actually in kids who are exposed to lead chronically at a young age. So again, if they have a nutritional deficiency in calcium and vitamin D, then they preferentially take up that lead because again, their bones are developing. They want to lay that down pretty quickly. And so that again, you can see how a lot of issues can be multifactorial, looking at both environmental, nutrition, spiritual, all these different things all kind of work it together. But again, keep an idea for what kind of different factors these represent, what they're used for. Okay, so we kind of talked about that. So this is the number of new cases over a defined study period divided by the mid-period population at risk. What do you guys think? The incidence? This is actually the incidence rate. Fantastic, right? So again, this is the number of new cases that happen over that period of time. But how does a rate differ from a risk? What's the difference between those two?
The risk play
Sure.
into the rate?
Hmm?
The risk play into the rate?
The risk does play into the rate, certainly, because you're looking at, so again, remember back to those graphs we were talking, remember the nursing home, the very sad nursing home, there are all those little ladies and men were dying, right? So again, remember that with rates, again, you can have the same risk between 3 different nursing homes, right? So again, if I had 1,000 people living in each of these nursing homes and 100 of them died, my risk of death would be what? 10%, right? 100 out of 1,000. So 10% would be my risk of death. That doesn't really tell me though, like when those people were dying, did they get hit by the flu? Did they have an issue where they, maybe Irma came by and knocked out power and they were out of power? Do you ever see those like really sad pictures of those little people in the nursing home where they had like the flooding that was happening there and they had just nowhere to go? Stuff like that could happen. It was really sad. Yeah, it was bad. I don't know if it was Harvey or Irma, but it was one of them. But stuff like that can happen, right? And that will influence when these people are dying or when this incident of this, whatever particular thing I'm looking at actually occurred here. And so that can change, and you want to be able to show that. And this is what rates are really helpful to show because they will kind of show those differences there and that kind of force of mortality, that force of whatever event we're looking at. And so the key period, or the key thing to note here is this mid-period population, right? We're not using the entire population we're looking at. We're looking at the average number of people that were alive or that were eligible for the event to occur in during that time frame, right? So again, we were looking at just at risk. What's my denominator? The whole population I'm looking at versus here we're using the mid-period population, right? So if a lot of people died all up front, that whole 10% died very early, then that changes my mid-period population versus if they were dying very steadily the whole time versus if they all died at the very end, okay? So that's what the rates are really helpful in showing. Again, if the occurrence is a very low percentage, then the rate looks very similar to the risk as well, right? So again, rates are very good for things that happen very infrequently, or for things you're looking at very kind of short time frames. Those are typically where rates are going to be a little bit better at helping with this, right? Does that make sense? Okay, so go back and look at those graphs, do the comparison between the three, and see how the rate changes based on, what the kind of the mortality patterns were between those three different kind of situations. Yes, ma'am. Well, if you're going to use rate, you want to use shorter time frames, because again, if you're looking at a very long period of time, you're going to find that you have a higher incidence of that thing happening. So again, if I went for like 2 years, then and that risk stays the same. So again, it's 10% per year. I have more and more people dying, and so that population, that number that I'm using, my mid-period population, starts to get lower and lower. And so at that point, my denominator changes greatly from what the actual original, if I was calculating risk, would be, because that's the whole population. That changes more drastically, right? If I were to extend that out, that mid-period population gets lower and lower. Because again, ideally, if I were to extend that out, say for 20 years, all the people are going to be dead at some point, and then my mid-period population would be very, very different than what I was starting out with. That kind of makes sense. Okay. Everyone with me so far? Okay, this is the observed total deaths in a population divided by the expected deaths in a population multiplied by 100. Accrued death rate. This is a version of mortality. Standardized mortality ratio. So again, that kind of makes sense because we're looking at a ratio. We're looking at the number of people. So you guys remember that example we went over, and I should have checked the YouTube video views before I came in here to see what they were looking like, but I didn't. Everyone the benefit of the doubt. You all have been diligently watching the videos as we've gone along. So basically what you're doing, remember that example where we're looking at the guys who are on the oil rig and wanted to compare their death rates versus, say, the death rate of the general population. We wanted to find out if they were more at risk for death being out on an oil rig than they would be if they were just on mainland, right? So by doing that, we can get this kind of standard mortality ratio. We can kind of figure out what the ratio is between their death rates and what the kind of standard population would be. And so we use a standardized mortality ratio. And so in that case, remember, even though the crude death rates looked like the guys on the oil rigs were actually dying at a higher proportion, if you looked at the actual age breakdowns, and again, age-specific death rates are super important here. We'll talk about that a little bit later. You need to factor that in. So again, based on the kind of the breakdown of the ages of the guys on the oil rig, they tended to skew that. Actually, their mortality ratio is lower than the actual general population. Maybe they're more active, maybe they're healthier because they're on an oil rig working 24/7, whatever it happens to be. They tend to have a lower death rate when compared to the general population. So their ratio was lower. So again, that number would be less than 1. Obviously, they would have a reduction in that mortality based on that, right? Again, why do we multiply it by 100? Yeah, so that we're doing with percentages rather than just dealing with like a fraction or something like that. So it's easier for people to kind of contemplate in their head if they see, they had a 60% reduction in mortality, or they had, say a 20% increase in mortality, whatever it happens to be. That's easier for people to kind of think about in their head, especially when you're communicating with patients. You're saying like, what are my chances of this happening? 20% versus 0.02. Like, no one really knows that, right? Or 0.2. Okay. This is a proportion of individuals with a given condition who die of the condition. So these are people that have the disease and those that die of that disease. It's the fatality, the ratio, good, and their cases of disease, so case, fatality, ratio. Absolutely fantastic. Yep, so we work through that. All right, you can look at the definition and kind of get an idea for what we're actually talking about. It's the case fatality ratio. So remember, when we're looking at that that entire kind of pie of people, so we have people who are at risk for developing the disease, but do all of them actually contract it? No. A percentage of them will, right? So then you actually have your cases. Are all the people who have disease going to become symptomatic? Not necessarily. So a percentage of them, a smaller subset of those people that become symptomatic, are they going to die? Not necessarily, right? So you're going to get smaller and smaller pieces of the pie. And so this is basically going to be this case fatality ratio, the percentage of people who died in comparison, the number of people who died over the number of people who actually had the disease in the first place. That's the case fatality ratio, if that kind of makes sense, right? Just keep in mind those kind of different little slices of the pie as you get the number of people exposed being the biggest proportion, and it gets smaller and smaller and smaller as you get more kind of serious kind of conditions like this. And remember, like when you have a new disease is kind of being found out about, so think about you guys were familiar at least with the Zika virus outbreak, right? You guys weren't in school necessarily at the time, but you at least were familiar with it in news reports and things like that. When you have a new disease that kind of comes about like that, is that the numbers that they report, is that always all the people who had the disease? No, what do you call that phenomenon? We're only looking at really the more severe cases, the very kind of early cases. The iceberg, right? Exactly. So we have a lot of people we're not actually capturing with that point, but we get these really high profile cases where you're like, look at these, these 40 people who had the actual disease and they had these birth defects. That's probably underreporting to quite a degree of all the people who actually have, who may have contracted Zika. I don't actually know what the numbers were, but typically you're leading a very small proportion there. And again, when you have a disease like that come about, what do you think that happens to people who are just kind of lay people who are at home, they're just watching the news, and they come down with a cold? What do they think they have? Yeah, now they think they have, right? Or like, SARS was the big thing. They're like, oh, everyone had SARS coming into the ER. So does that actually increase the number of diagnoses of SARS you're going to make? It's hard to tell, right? A lot of those cases are going to be false positives. In a lot of cases, they're going to think they have when they really don't, so they're going to have some other sort of disease state. But again, it's one of those things we have to be really careful when when news stories come out about a certain thing, everyone all of a sudden thinks they have it, right? Okay, this is the number of live births divided by the mid-period population. Yeah, it is. So it's a rate. Good. We know it's a rate because why? We're looking at a mid-period population, right? So that's very important. So we know it's a rate. It's not just a risk of a baby's being born. It's a very risky proposition. Hopefully mine's about to be 100% pretty soon. So again, looking at the crude birth rate, right? So again, we're not really standardizing it to anything. We're just looking at the number of births we have divided by the mid-period population. So this is really important because when you're looking at rates, you have to consider what is your denominator, right? So for instance, if I were using the entire US population, is that appropriate for this kind of rate? No, why not? Thank goodness, men cannot have babies, right? So because of that, they would not be appropriate to include in that kind of in that denominator there, right? So all of a sudden you're cutting your population in half. Now all of a sudden our birth rates look a whole lot better, right? The other thing you have to consider though is like, okay, if you're using all women, is that appropriate? Probably not, right? Because again, who are you including at that point? Yeah, people who have non-childbearing potential, right? So very, very young women and very, very old women, probably unlikely to give birth anytime soon. So again, they would kind of be inappropriate, but oftentimes we're using those numbers because it's harder to figure out like, who exactly is of childbearing potential, so because of that, it may be a little inaccurate, but it's better than nothing in a lot of cases. And why do we look at infant mortality? Why do we care about that? Good, yeah, so it reflects the healthcare of the society, so we can kind of look a little bit closer like apples to apples, looking at, okay, well, obviously babies are surviving better, we're taking better care of them, and then also we're taking better care of the moms, kind of is indicative of, access to healthcare and things like that. So it's a good way to kind of compare different countries and things like that, to say, well, how good is our healthcare essentially, right? But again, with stats, you can lie with everything, right? So again, you can sometimes say like, well, America has the worst or the best of everything. You can skew the numbers depending on how you change what your denominator is, what your numerator is. So you have to be really careful when you're kind of looking at these claims, whether they seem really good or really bad. And you have to kind of look to say, well, what actually were they comparing here? Is it a fair comparison based on, were they looking at appropriate number of people who are at risk for this actual event or not? Things like that. So you can lie a lot with statistics. Very, very easy to do. We've already illustrated that oftentimes in this class. Okay, this is going to provide the death rate within a defined age range. Age-specific death rate, perfect. All right, see? Guys can figure out these definitions, no problem. So age-specific death rate, why are these important to look at? Well, who's more likely to die, an old person or a young person? Probably an old person, right? Anyone ever seen The Giver? Or you read The Giver, I guess, back in the day. Right, so again, old people are probably going to be more likely to die, right? So when you're looking at just crude death rates, if you're just looking at the number of people who died in a population, you also have to factor in, like, well, were they an older population, were they a younger population? Because that can skew your results pretty significantly, right? Because remember, we're looking at one, we're comparing, I think it was like Switzerland versus, it was like Brazil or somewhere like that, some South American country. They had a much, they skewed a lot younger in the South American country versus in the European country, they tend to skew a lot older. So their death rates looked a lot worse. But when taking into account the age-specific factors of it, by kind of divvying up people into different age brackets, you could see that, you know, the people in the European country tended to do a little bit better, actually, when you kind of took in those features into account.
Are we using the mid-period population for just a rate here, or are we using the whole population of that age?
So you have to look at that. You have to look at the type of study you're doing. But if they're talking about specific rates, then you need to look at the mid-period population, right? So, and again, when you're looking at these type of studies and things like that, you want to look into their methods and see, like, how do they actually come up with these numbers? When they say rate, did they actually mean that, or are they just looking at risk? Or what are they actually looking at? That's an important feature to look at in these studies.
So if they weren't looking at the mid-period, then it's what the risk they would have been looking at?
Yes, you're looking at death risk during that time frame, right? You can still do it on age-based, still break it, because again, age is always considered. We talked about, like, in our other studies, when you're introducing things that kind of influence the results. What do you call those? Yeah, those introduce bias or confounders. So age is one of those things you have to adjust for, because we know that mortality is so different between a very young patient, a middle-aged patient, or an old patient. Okay, so now a little scenario here. Let's say we have a politician. They're throwing a luncheon fundraiser, and they're serving up various types of seafood, including a lovely salmon musée. And within 24 hours, they had 17 diners in total, and 11 of them came down with abdominal pain, vomiting, and diarrhea. Okay, of the 11 symptomatic patients, 4 had fever, 7 did not. Of the 5 of them, they had elevated white blood cell count, 6 did not. Now of that 11, 6 of them ate the shrimp bisque, 5 did not, and then 9 ate the salmon, 2 did not. Okay, and so one of them actually ended up going to the hospital. They actually ended up coming down with actually had their acute cholecystitis, had the gallbladder taken out, and then let's see, of the 11 symptomatic, 10 recovered in 3 days, except for this guy who's in the hospital for a few days recovering from surgery. Okay, so taking this into account, let's ask a few questions and see if we can ascertain a few conclusions about this type of study. So this phenomenon, is it a coincidence until proven otherwise? Is it a disease outbreak? Okay. Is it attributable to bacterial infection? Maybe we don't know. Is it an outbreak, or it's not an outbreak because the usual pattern of disease is unknown? Or should it be investigated by the CDC? Is it a case of biological terrorism? Perhaps. We don't know yet, do we? What do we think? So imagine if you were going to a luncheon, 17 of you decided to go out to lunch after this. Within 24 hours, 11 of you came down with horrible vomiting and diarrhea. Would you consider that to be normal? Unlikely, right? So this seems to be an abnormal occurrence of disease. So what do you call that? An outbreak, absolutely. So again, it doesn't have to be like the movies sort of outbreaks. It can be as minimal as something like this, right? So again, a lot of things is kind of interesting because the Poison Center, we had our ties with the Department of Health. That's actually who we were under as far as like funding goes and things like that. And so one of the things we did is because the Poison Center is open 24/7, 365 days a year, we would get a lot of cases of food poisoning that actually come to us. So people ate at the Golden Corral and they're like, hey, I ate this potato salad. It looks like it had been there since like last Tuesday. And now I come out with this horrible vomiting and diarrhea. We would take all that information and we would send it over to the Department of Health. And that way they could see that if multiple people were calling in with the same thing or they have multiple reports, they can kind of go back and look to see, like, okay, well, what the heck was going on? Is this actually a disease outbreak? Is it just a coincidence? They can look back at that. So, food poisoning outbreaks is one of those big things that the health department kind of on a state level can look at and can kind of help to investigate. It can be a very useful kind of thing there. So, what do we think? Probably a disease outbreak, right? So again, this is an uncommon occurrence based on what you would expect after a particular event, right? So again, 11 people out of 17 coming down with this is kind of abnormal. Okay, so we consider this a disease outbreak. We kind of talked about this. Again, would the CDC investigate? Probably not. I mean, maybe if it was a bunch of like high-ranking politicians, they may kind of look into it just because it's kind of high-profile kind of thing. But when does the CDC usually get involved? More widespread. So widespread. How widespread? So perhaps statewide, especially if it's very severe, but what if it even went beyond state lines? So usually, yeah, interstate kind of concerns, that would be a big one, right? So if again it was crossing borders, that would be a big thing to consider. Also, they can go based on requests, right? So it could be disease severity. If they get reports that, hey, this really bad thing's happening, they can go can go investigate that. If it was requested by a particular group, perhaps they may go out there based on what they look at. Sometimes they'll kind of work in conjunction with Department of Health, things like that. But even things you may not think about, the CDC can investigate. So if you're looking at things like one of the big things we're concerned about from a tox world is novel street drugs and things like that. So looking at, you remember like when K2 or spice was coming out, synthetic cannabinoids, and we had things like bath salts that were coming out. That was a big deal, right? Because we were getting a lot of calls coming from ERs, and they're saying like, hey, this guy took this, he snorted this powder. I have no idea what the heck's going on, but his temperature is 106, his heart rate's 180, his blood pressure's through the roof, and he's going into rhabdo, right? That's very abnormal. It's a very severe sort of thing. And we saw cases like that with these new novel drugs. That is something the CDC might actually come down and investigate because it is so severe and has implications to impact a lot of people, right? Because again, where do you think a lot of people were buying these products? Gas stations is a big one. What's the other place? You all use it every day. The interwebs, right? So they could buy it online, right? They can get access to this sort of thing. So again, this could be something that impacts the entire country potentially. So that was one of those things that they looked at and investigating there. So again, not everything you might think of. The CDC kind of has a lot wider reach than you might actually suspect. So what is the attack rate for this particular case? What do you think? Is it 4 out of 11? 5 out of 11? 11 out of 13? 11 out of 17? 1 out of 17? It's 11 out of 17, right? So why 11? Those people became symptomatic, and why 17? Yeah, those are the people that could have been at risk, right? Because they were the ones that are all eating at that time. Those are the number of people you'd want to look at when you're trying to do this investigation to see, is this actually something else that's going on, right? Good. So that kind of makes sense. Again, 17 are going to be our denominator here because those are people at risk. 11 are people that became symptomatic. Again, did everyone become symptomatic because of the same cause? Not necessarily. So you don't know yet, but because they became symptomatic, you're starting with a wide net, and then you're going to kind of narrow that down when we start talking about case definitions, right? So again, looking at all people who became symptomatic, and then ruling people out based on like, okay, well, were they diagnosed with acute cholecystitis? Yes, get rid of that person, right? They may not count potentially based on our definitions, as we'll see here in a minute. Okay, so in early priority, when investigating this phenomenon, they should close the kitchen temporarily. They should define a case, perform a case control study, perform stool tests, or submit food samples to the laboratory. What's the easiest, quickest thing we can do? Define the case, right? We want to figure out, okay, who exactly are we looking at? Who we're going to do further investigation into? So we want to define a case. Again, we want to start easy stuff and go deeper, right? Just like when we're dealing with patients, you want to start with the easiest things. When you see a patient who comes in for chest pain, what's the first thing you're going to do with them? You're going to order an EKG, but you're going to do what with the patient first? Just talk to them, get a history, right? You're going to talk to them, figure out, okay, do they have a history of MI? Okay, that's going to strengthen my thought that this is probably another MI, right? You're going to go down that line and do the easy things first. I'm going to define a case. Okay, and again, this helps us to establish a diagnosis. This is, again, along that pathway of getting a diagnosis, getting our definitions here so we can do better investigations. Because, again, you don't want to go and send every bit of food out there to get a sample because it may not be super useful. You want to be able to kind of target your investigation, try to be as be efficient with your resources as possible in these cases. So in this case, the best case definition for the guest would be they had abdominal pain, vomiting, diarrhea within 24 hours of the state luncheon. They had acute viral gastroenteritis, staphylococcal food poisoning, onset of abdominal pain and fever after the state luncheon, or vomiting, diarrhea, and elevated white blood cell count. Think A? Think D? What do we think? So again, we want to be pretty specific with this, and so again, this is good. A is going to be really nice for because it's going to be able to provide this kind of temporal link to the event in question, and it's also going to be not so specific, right? Because again, if we look at just people who came down with staphylococcal food poisoning, that may not actually capture everyone, or it could not have even been staphylococcal food poisoning in the first place. We just don't know at this point, right? We don't know if it's viral. We don't know, if it's something else. So again, we want to be inclusive of all the people who became symptomatic, but not rule things out prematurely, because again, we just don't have that information yet. The temporal association is really important as well, right? If you go back and look at some of those slide sets, we were talking about how, the temporal association, looking at, what the incubation period is, and kind of looking at those ranges, you can kind of get an idea for pinpointing exactly when the exposure actually occurred to figure out better what the actual exposure was that caused this, right? Okay, and again, when you're doing this definition, are we going to potentially get false positives? Yes, it's still general enough. You may get false positives, but that's okay. And we want to start with things that are highly sensitive. We want to start with a very wide net, so then we can then rule people out later, right? So again, remember spin and snout. So we start with what type of test? Highly sensitive tests, because again, they're going to cast a wide net. They're going to capture a lot of people. We're going to have a lot of what? False positives or false negatives? We're going to have a lot of false positives, but that's okay. We can rule those guys out later on, right? So again, we want to start with a very sensitive test. And then later on, we're going to move over to more specific tests later on. It's going to be able to, better confirm our diagnosis. Okay. Okay, so let's say we're suspecting that the disease is a result to a common source of exposure involving contaminated food. The investigators attempt to try to determine which food it is. So their initial task should be to analyze food specimens in the lab, perform some CSI-like maneuvers, close the kitchen, examine the food preparers, see if they're picking their nose or something like that prior to making the food, interview symptomatic guests to find out what they ate, or perform a case control study. Yeah, find out what they ate. That's the easiest thing to do. What was the common link here? Did all the people that became symptomatic, did they all have the salmon? Did they all have the shrimp? What could have been the common link here? So again, you may still find people who may not all be consistent necessarily, but you may start to get a better idea of, okay, this may be the thing that actually is the common link between these guys or these people that became symptomatic at this point. But again, simple things initially, simple interviews are going to be the easiest thing to do. Typically, you're collecting this information anyway. Okay. So good. So that's kind of the main thing, the main thrust of that case scenario there. But let's look at a screening program. Let's say we're going to initiate a big screening program. What would kind of be an analog to a late look bias? You guys familiar with the late look bias? So imagine you have a disease state. Imagine you're looking at something that is potentially fatal, right? So let's say we're looking at, say, COPD. And we're looking over a long period of time, and or actually we're looking backwards at a period of time. We're going to start to interview patients right now to see if they have COPD or not. Who do you miss if you did just kind of this single time point? So people who are still alive with severe disease, you would still be able to capture, right? Because they actually have active COPD. But who'd you miss? People died earlier, right? So again, those people are not alive to be diagnosed with COPD. So that's considered what we call it kind of a late look bias. But let's say we're doing a screening program. So say we're looking forward in time instead of looking backwards. What would kind of be an analog to that? So it'd be a length bias because cases lasting longer are more likely to be detected. Is it recall bias because only people remember their severe illnesses? Is it selection bias because the program selects out for asymptomatic illness? Is it selection bias because the program only selects out for severe cases? Or is it more likely to be spectrum bias because all the patients tend to get clustered in one end of the disease spectrum? I guess think. So again, we're looking for an analog. We're going to be missing patients because maybe they're not around anymore. So actually, it's going to be pretty the length bias, casting lasting longer, more apt to be detected here, right? So again, patients, again, screening program. Do you hit every single person in the population you want to screen all at the same time? Probably not, right? It's going to be kind of a more ongoing kind of process there. So you still have a chance to be missing some of these patients, but those who have kind of longer, more kind of indolent disease tend to be more likely to be caught here. Kind of an important thing to get these different types of biases and see how these can affect things like your screening programs. Typically, you're going to find that recall bias is not a big thing with prospective sort of studies because, again, you're not asking people to remember things. You're trying to screen them for disease at that time period, right? And so you're going to see some more like kind of retrospective studies where people, if you're surveying people or interviewing them, they may forget that like, oh yeah, I had the chicken pox when I was a kid or something, right? Or they may forget they have a particular disease state or they had certain symptoms when it occurred or what type of treatment they received. So that really wouldn't be analogous or analogous to this. Typically, screening programs are designed to pick up on asymptomatic individuals, right? Because you're trying to screen for those people who are not really have like the really obvious cases, right? You're going to get the severe people, but you're also going to get hopefully the asymptomatic ones, depending on what your criteria is going to be when you're looking at using tests with either usually high sensitivity, but also looking at the specificity of these tests as well. That kind of makes sense, perhaps. Okay, so remember your biases, kind of look into those, seeing how they can affect the study. Some of it could be related back to the patient, some of it related back to the investigator and how they decide to allocate individuals, how they're collecting data, things like that. Okay, let's say we're going to do a study. We're going to conduct this to look at the effects of drinking Mountain Dew on a teenager's willingness to bungee jump from frightful heights. Do these patients, are they more likely to do the do? That is the question we'd like to find out. Let's say we have a total of 500 teenagers and they're assembled on the basis. This would be very unethical, by the way, to force a bunch of teenagers to jump off of a bridge. As much as you may want them to, still unethical. But let's say we were doing this hypothetical study. We have 500 teenagers that are assembled on the basis of bungee jumping status. You have 250 of them are jumpers, 250 of them are not. There's a proportion they're like, just leave the rope off me, I'm just jumping anyway. But we're going to get help for them. Okay. Anyway, of the 250 jumpers, 150 of them report drinking Mountain Dew. Of the non-jumpers, 50 report drinking Mountain Dew. Most of the non-jumpers report a preference for warm milk. I did not make this up. This is actually handed down to me. I don't know where this came from, but I am going to leave it in here in perpetuity. So which of the following statements do you think is true here? Do you think jumpers and non-jumpers should be matched for their beverage consumption? Do you think the absolute and relative risk of bungee jumping can be determined from the study? Do you think this is a cohort study? The study can be used to calculate an odds ratio, or unanticipated outcomes can be assessed in the study. So question, what type of study is this? So how do we break up the patients? So is it a case control? So it actually is kind of a cohort study, right? Because we're breaking up patients into what basis? Based on if they're jumpers or they're not jumpers, right? So we're looking at one outcome, and you could have done this as a case control study, right? You could have looked at people who were bungee jumpers and then matched them with cases or controls of people who were not jumpers, and then looked backwards at their beverage consumption. But in this case, it's kind of an odd one where we're actually looking at a cohort study, but we're looking at we're looking at the risk factor, but we already kind of know what the outcome is. We know if they're a jumper or not jumper already. Okay, so again, it's kind of an odd one, but the points kind of remain here. So again, that's our we're looking at for the risk factor. We're looking to see the risk of them drinking Mountain Dew and see if that influence whether or not more people drinking Mountain Dew, did that predispose them becoming a jumper versus not, right? Because typically in a case control study, you end up having kind of one case, and then how many controls do you normally have? One, more than one? Usually more than one, right? Because in a lot of cases, when you're doing a case control study, like you don't know what your entire population is that could have developed the disease or not. You're really dealing with a small subset. You're doing a subset of cases, and then you're matching them with several control patients typically. Because again, you want to try to eliminate a lot of those confounders, and that's important because when you're looking backwards to see those risk factors, you're not looking at absolute differences in risk. What are you most often using when you're looking back at those case control studies? We're not using relative risk, but we're using odds ratios, right? You can't do absolute differences because, again, we don't have our full population. When you're doing a cohort study like this, you already know I have 250 people in this group, 250 people in this group. My denominator is kind of set at that point, right? Of a total of 500 people. When you're looking at a case control study looking backwards, you don't really have an idea of what your actual denominator is going to be. So in that case, you're looking at the odds of these people having this risk factor versus the odds of them not having the risk factor, right? And so that you get an odds ratio in that case versus actually looking at absolute risk differences or relative risk differences. That make sense? It's an important point to have there, that with case control studies, you're really only looking at relative differences, but with prospective sort of studies, cohort studies, you can look at absolute and relative differences. You guys got it? May come up again, perhaps. Anyway, so what do you guys think? So, like I said, this is kind of an odd study. I would probably consider it a cohort, but this person did not. Again, you're not really matching the same kind of cases to controls like you would in a typical case control study, but we can calculate an odds ratio, right? So we're looking at the odds of jumpers consuming Mountain Dew versus the odds of consumers not consuming Mountain Dew. Okay, so that's really kind of the big thing we're looking at here when you're using these sorts of studies, right? Yes, sir.
So, are we saying that this is actually then a case control since we're doing the odds ratio?
It's a weird one, right? It's kind of.
Usually you would do absolute
Right, so again, when you're looking at a particular outcome and then you're looking backwards at risk factors, this is where you're using our odds ratios. That's kind of the key difference there, is that when you're using kind of a more like a prospective sort of study, you're looking at the risk factor, that's usually how you're dividing people up, and then you're looking at the outcome, right? With this sort of study, we already know whether they're jumper or not, and then we're looking backwards to see what their risk factor was. So in this case, this is why we use odds ratios versus using like a relative risk, right? So we're not saying like, okay, here's all the Mountain Dew drinkers, here's all the non-Mountain Dew drinkers. What was the risk of them becoming a jumper versus a non-jumper? Make sense? Hopefully. Okay, so don't get really hung up on the case control versus cohort study. What you do want to get hung up on is the fact that when you're looking at a particular outcome, like you're starting with the outcome and you're looking back at the risk factors, that's where you're going to be using odds ratios. You can only get relative differences between those groups versus if you're doing a study where you're looking at the risk factors and then seeing what outcome happens, that's where you're going to be able to use absolute and relative differences in risk. So you just kind of take that point home. Okay. And again, we can't really do unanticipated outcomes because, again, we're only looking at whether they were jumpers or non-jumpers. That's kind of the big difference here, is that, you know, potentially if you were doing it based on whether they're Mountain Dew drinkers or not, you could look at different outcomes, but you need to do that stuff kind of prior to actually doing the study. So, again, all this stuff should be done a priori. You just don't want to look at kind of random associations afterwards because you may find kind of spurious things. Because, again, when you're looking at, you know, finding a statistically significant result, how often do you find a false positive? Probably like 5% of the time, right? Because again, our p-value is 0.05. That's our threshold for significance. So 1 in 20, you're going to find a spurious result, a false positive, right? Even though we say that's acceptable to us, but that is what that kind of means. Okay. So you only really should be using odds ratios here. Again, they might describe it as a case control study, but it's kind of difficult because it's kind of an odd one, as I mentioned. So again, when you have, usually when you're doing a case control study, you would say like, okay, these are the people that were jumpers, and we're going to match them with several control patients. That way you kind of lose a lot of those confounders. When you're kind of starting with a group like this, it's a little bit more kind of difficult to really call it a case control necessarily. But regardless, again, the fact remains they're using odds ratios here to compare their Mountain Dew status rather than looking at whether they're a jumper. We already know if they're a jumper or not, essentially. Make sense? Okay. So say we're doing an odds ratio, we calculate from the study, it would give the odds of drinking among jumpers to drinking among non-jumpers. It would be drinking among non-jumpers to drinking among jumpers, drinking Mountain Dew to jumping. Because so again, what were you dividing what by what? Jumping among drinkers to drinking among jumpers. This is really confusing. Again, I didn't write these questions. This was handed down to me, but they're still fun. Non-jumping among drinkers to non-drinking among jumpers. Isn't this confusing? So what is this? What are we trying to say? So based on the study, we know we have our jumpers, we have our non-jumpers. What are we looking at the odds of? Right. So the odds of drinking Mountain Dew in the jumpers versus the odds of drinking Mountain Dew in the non-jumpers. Right. That's the odds ratios that we're looking for there. In this case, drinking among jumpers to drinking among non-jumpers. Right. So again, don't get hung up on this, but just look at what your outcome is. We know what the outcome is, and then look at the risk factor here, and that's what we're kind of getting the odds of to see if the jumpers had a higher odds of drinking Mountain Dew than those that did not. If you guys ever wonder why there's a bottle of Mountain Dew in my office, one of my previous students gifted that to me after this example here. So I don't need any more Mountain Dew. I'm a Diet Dew guy. Anyway, so again, we're doing odds ratios. We're doing the odds of drinking Mountain Dew in those jumpers versus the odds of those individuals who are not jumpers drinking Mountain Dew. Right. So again, you're just dividing one by the other. We are not getting the same. It's not the same as like a relative risk. This is looking at the odds of something happening versus not happening, essentially. And again, you can kind of call this, when you're looking at an odds ratio like this, you're kind of considering it to be the risk of having a risk factor, essentially. That's another way you can kind of think about it is, you know, what is the chances that these people have this risk factor who had this particular outcome? So that's kind of another way you can kind of think about it. Okay, so the results of the study indicate, so again, if you go back and look at the numbers there, bungee jumping and beverage choice are associated. Bungee jumping and beverage choice are causally related. If I say causally related, what does that mean? Right, so did me drinking the Mountain Dew make me go jump off of a bridge? Probably not, right? Maybe it's an intervening factor, but probably unlikely to be a causal factor here, right? Bungee jumping influences a person's choice of beverage. So do bungee jumpers, they just say, I got to drink Mountain Dew because that's What bungee jumpers do? Probably not, right? Choice of beverage influences a person's tendency to bungee jump, or there's no association between warm milk and bungee jumping, I think. We see that they're associated, right? So again, if we did the p-value, you'd probably end up seeing that the odds ratios would be significant. Again, when you're looking at an odds ratio, if there were no difference between the two groups, what number would you get? You get 1, right? Because the risk of having that particular risk factor of drinking Mountain Dew would be the same between the jumpers and the non-jumpers, right? To be 1. So in this case, we would end up seeing a number greater than 1, showing that those people who are bungee jumpers, they were more likely to have drank Mountain Dew. But again, we see an association here, and it does correlation mean causation? No. Again, that's one of the big things to take away from this. Just because something's associated doesn't mean it's not, just a spurious association does not mean that there's any kind of causal link here. Further investigation has to be done to actually figure out if that is the case or not. Perhaps a random dye in the Mountain Dew mind control people into jumping. Who knows? We don't know that yet. We just know there's an association, right? Yes?
How do you determine which one's the numerator or the denominator?
So your question, so that kind of comes in from the original study question. So I wanted to see if people who are jumpers were more likely to have drank Mountain Dew than people who are non-jumpers. So again, that automatically puts the jumpers in the top category in the numerator, because again, they had a higher proportion of them were drinking Mountain Dew. So this is why that odds ratio becomes positive, right? Now on the flip side, if you were looking at this question, you were looking at jumpers versus non-jumpers and whether they're drinking warm milk or not, right? You would assume that the jumpers had a lower warm milk consumption versus the non-jumpers. So at that point, your odds ratios would be what?
Negative.
Not necessarily negative, but we said if there's no difference between the groups, it's 1. It would be less than 1, right? So it would be, say, 0.6 or something, right? So again, we're looking at making sure that if you're doing a relative difference between risk or odds ratios, like 1 is that point where no difference. Is you either want to go above that if it's more likely to occur, or less than that if it's less likely to occur. Okay. So again, you'd have to reach further conclusions about that association. Again, maybe that's a good hypothesis generation to do further studies. I don't recommend doing this as part of your graduate project, unless you just really like bungee jumping and chugging Mountain Dew. That may be a thing you like to do. Anyway, any questions that have come up since you've been percolating on it for the last 10 minutes? At least reassembled your brain, the gray matter, into a cohesive form for more questions, right? Fantastic. Let's keep going. All right, so let's say we randomly assign subjects to 2 years of PA school. You guys are all subjects. Great. So this is the intervention, or 2 years in graduate school. This is our control, okay? And we're going to test for evidence of mental health. Their outcome. Let's say we have 100 subjects assigned to each condition. You find evidence of mental health in 12 medical school group, and I don't know why I said medical. I think I meant to change it to PA school, and 92 in the control group. So evidence of mental health. The other 82 or 88 had no health whatsoever, no mental health. So anyways, let's see. An appropriate measure of association in this study would be incidence density, power, likelihood ratio, odds ratio, or risk ratio. So what do you think? How would we compare these outcomes? You like to do a risk ratio? Why? So again, how do we design the study? So how would you describe it? It's a cohort study. We decided to give them either the intervention, PA school, or they went to regular graduate school. I guess there's nothing regular about it. We went to a graduate school, and then we compare for the outcome to see what happens. We're looking for the risk of that outcome actually occurring here. Perfect. Now, could you look at absolute differences in risk? Absolutely. All right. So you can look for absolute differences. Now, had this been a case control study, you're looking backwards. You cannot do absolute differences. You can only do those odds ratios, right? And again, we kind of discussed that in the lectures, why that is. But basically, because we know what our full denominator is here, we know what we've kind of defined what this study population is. We can do those kind of absolute differences because again, we have evenly assigned these groups. They have 101, 100 in the other, and we can figure that out very easily. So again, but most often you're going to find risk ratios. And again, if I were to do a risk ratio, if there's no difference between the groups, what would I find that risk ratio to be? It should be 1. If I did an absolute risk difference and there's no difference, what should I find? It should be 0, right? So it's important to remember, if you're doing absolute differences, if there's no difference, it's 0, right? If there was a reduction in an absolute risk, what would I find? be a negative number at that point, right? Because again, it's been diminished. That risk has been reduced, and so you end up seeing a negative number in that case, right? So again, kind of think in these types of studies, look at the tests they're doing and look to see what the results are being described as, and if that makes sense based on the numbers that they're showing and whether they classify those as significant or not, right? And again, if I was doing like a risk ratio and I gave a confidence interval, say the risk ratio was 2, and the risk ratio, the confidence interval 95% went from say 0.5 all the way up to 4. Would I consider that to be significant? No. Why? Crosses 1, right? Because again, I'm doing a ratio. 1 shows no difference. If I have a confidence interval that crosses that, then I can't really say that's statistically significant at that point, right? So again, that's why I want to narrow those confidence intervals to make sure we find significance where appropriate there. Okay. Yep, so odds ratios are going to be more in those case control studies where we already know what the outcome is of whether mental health is present or not, and then looking backwards to see, what type of schooling they were exposed to, that being the risk of having that risk factor of PA school versus, say, like some other kind of graduate program, right? Likelihood ratio is going to be more to evaluate the utility of a diagnostic test, so that's going to be more like, what kind of test do we use for, diagnosing someone's having mental health or not. That would be where you could use things like likelihood ratios. Kind of gives you an idea how good a test is, right? So things with a very high likelihood ratio. If you have someone who's positive, it truly means they probably are positive. That can be very good utility when you're kind of comparing different types of tests. Yes, sir.
If you were to do a retrospective cohort, because I know you discussed that in the lecture, do you do relative risk or odds ratio?
Yeah, and those are less commonly done. But basically, what I would do is I would arrange it by I would look backwards. So I would say, like, okay, I'm going to look back and say the year 2000. I'm going to look at these 100 PA students versus these 100 other graduate school students, and then I will look to see what the outcome is. It's not as statistically sound as if I were to do it prospectively, because again, you may, there's always the chance I can change whatever outcome I want at that point because I have all the data, right? And so not as statistically powerful, but can get the job done in some cases, especially if you're just kind of doing kind of early hypothesis generating sort of studies. Yep. Absolutely. But yeah, you can still do absolute or relative differences because, again, you were defining what that study population is going to be, right? You're saying, like, these are the number of people I'm going to be looking at. This is my denominator. Okay. Okay. Incidence density. We said that's going to be, when do we use incidence density? That's going to be useful when we're talking about things that can happen multiple times in a given study period. So remember we talked about the example of acute otitis media, right? So it's not like death where once you die, unless you're a vampire, you don't really come back, right? Or cat maybe. But as far as acute otitis media, you can have multiple occurrences of that, right? And so that is good because you can look at, say, a number of patients. Say I look at 10 patients over, say, a 10-month period, and if they have, say, 20 cases of acute otitis media, and it could have been one person could have had 8, one person could have had 2, or one person could have 0. I can figure out what that incidence density is. So I would say 20 per, say 10-person months, essentially, right? Or whatever it happens to be. And so you can then look at that comparison between, say, like the group that maybe had tubes placed versus those that didn't, right? And that, by getting that kind of the incidence density of the number of cases per person months, and again, you want to make sure that person months are the same, so that way the denominator is the same. You can make apples to apples comparisons. You can see which one had better outcomes, essentially. Okay, that's a good thing to consider there. Right. So again, that can most useful for things that can happen more than once in an individual patient. Okay. Next off, we wish to determine the proportion of MIs that are fatal within 24 hours of their occurrence. You decide to examine records for all EDs in physicians' offices that are local. You then calculate the proportion of reported MIs that resulted in death in 24 hours or less after the patient was initially seen. Okay, so we're looking for that initial 24 hours who died. You briefly discuss your plan with a friendly neighborhood biostatistician who immediately points out your study is particularly subject to which of the following forms of bias? Is it late look bias, lead time bias, measurement bias, observer bias, or selection bias? What do we think? Hopefully none of you have a friendly biostatistician, because they don't really have friends anyway. This is a purely hypothetical event. Neither do pharmacists, so don't worry about it. So this tends to be a form of late look bias. Anyone think of why that might be?
Because they're dead by the time you do the study.
Yeah, so what type of MIs would I be missing? So again, we're only capturing people who showed up to the ER or people who showed up to the physician's office who died within that 24 hours. Who am I missing at that point? Yeah, people could be dead on dead on scene, right? So people could have already had that MI, already been dead, and that would end up missing those myocardial infarctions, right? So that could be a form of late look bias there. Again, you're only detecting the cases of a serious disease or and to be mild enough to be detected before that actual death occurred, right? So it's one of those things where severe enough to actually pick up on it, but we were able to catch it in that period of time to where it was still able to be detected, right? So again, a lot of those cases happen before they even reach the ER, and so you end up kind of missing those, and so you'd have an underreporting of the actual MIs that were occurring in those cases, right? Now, certainly you could do something where you're looking at a particular intervention once the patient hits the ER, and say, okay, MI shows up at the ER, and like we're going to cool these people down to whatever temperature, and we're going to leave these people at room temperature, at their normal temperature, and see how they compare. That would be fine, but cases where you're just looking at MIs that die within 24 hours, you miss all those people that were already dead to begin with, right? Before they ever reach the ER. Okay, so looking at the mosquito involved in transmission of malaria, it assumes a role of what? Is this an animal reservoir? Is this a commensal role? Is it a parasite, a surrogate host, or a vector? Vector, right? So we covered this in micro, correct? I imagine you guys covered that. Perfect. Good. So again, remember, so we have the host, we have the vector, the mode of transmissions. Remember all those kind of features there, how any changes in those can change, the actual occurrence of disease, occurrence of death. Good. So, which of the following best describes the effect of vaccination against diphtheria when the disease was more common than it currently is? So, frequent exposure resulted in boosted immunity after immunization. Frequent exposure resulted in an infection against which vaccination was not protective. Susceptibility to severe infection redeveloped several years after vaccination. Vaccination resulted in hypersensitivity to the infectious agent. Vaccination resulted in unusually severe clinical disease when immunity was not achieved. So, which one of the ones do you think we can rule out based on this? So, we're comparing when the disease was more common versus when it is currently. So, you see, we should say yes or no. See, no, okay, we can probably rule out C, right? So, susceptibility to severe infection developed several years after vaccination. Probably not, right? Because then when it was more common, people were more likely to be exposed to it, correct? So, again, what kind of effect does that have? Almost like a kind of boost in the immune system, right? That booster effect, right? So again, when you think about a disease that's been practically eradicated, you don't ever get re-exposed to it. You can never, you may not be able to retain that kind of that integrity of the immunity over a long period of time. So again, why is that, that we get repeated courses of some of these vaccines? Because we don't really ever get exposed to it, right? So again, you don't see a ton of cases of measles, but we oftentimes get MMR before you go into school, before you get into college and things like that. So you're kind of redosing them to kind of boost up their immune system in those cases. So again, back when the disease is more common, you have more exposures to it, you get that booster effect. Otherwise, we have to give, as a healthcare provider, give the patients the booster effect for them, essentially, right? And again, this kind of developed immunity is always going to be stronger than what we're actually giving them in a lot of cases. That makes sense? So again, with these kind of answers, look at things you can kind of rule out pretty obviously, right? So rule out the obvious ones and then say, okay, well, narrow down between 1 and 2 and kind of go with whatever your kind of gut's telling you. Okay. So again, kind of read all of that. It's kind of what we already talked about. Okay. Data reported for cases of relatively mild diseases such as chickenpox could generally be characterized as highly accurate because of active surveillance, useful for establishing prevalence but not incidence, valuable for detecting changes in the pattern of the disease, valueless because mild diseases are underreported, or valueless because most patients with mild disease do not present for medical care. I think. So do you think it's highly accurate because of active surveillance? Do we do active surveillance for chickenpox? Not typically, all right, so that would not be correct. Is it useful for establishing prevalence, not incidence? Probably not, right? So because again, you're not really getting a lot of those cases because again, is everyone going to the hospital for chickenpox? Not typically, right? So again, you're going to be missing a lot of those cases. So again, it's not necessarily good for establishing that prevalence. Now, we're going to have for most infectious diseases, you typically find underreporting, right? Those really kind of high profile or like really deadly ones, you typically get a little bit more better reporting on. But again, it's useful for looking for trends over time. You know, those kind of big things you're kind of looking for with this kind of reporting. So if you see a big spike, then you know, okay, well, something's going on here. There's been a change in how frequently people are getting diagnosed with it, or the change in severity, things like that. But again, we can look for changes in patterns of disease. Even though we know it's underreported, we can look for those changes in time to see, okay, is this a new strain? What the heck is going on here, right? So, again, not completely valueless, but probably not as absolutely valuable as if we had some kind of active surveillance program. But again, how much bang out of your buck would you get for doing active surveillance for chickenpox? Probably not a lot, right? But for certainly, for other things, we require them to be reportable. Things like HIV, things like TB, and all that stuff gets reported up. So that way they can look for those trends over time as well, right? Okay. Following deaths reported for a population of 2,807 men, aged 35 to 68. They had 4 deaths in non-smokers, 11 deaths in men smoking 1/2 pack cigarettes per day, 18 deaths in men smoking 1/2 pack to 1 pack per day, and 43 in men smoking more than 1 pack per day. From this, what can we conclude? Smoking increases mortality? Perhaps. The relationship between mortality rates and smoking is linear. There's a dose-response relationship between smoking and death. To interpret the data, the age at death is required for each case. Okay. And then to interpret the data more, the information must be expressed as rates for each risk group. What do we think? So again, some of the stuff may seem kind of obvious, but it may not quite be obvious from a kind of epidemiologic standpoint. So again, we really need to be expressing these as rates for each of the risk groups, right? Because again, you may find that people who are smoking more die at a faster rate. So again, those rates are going to be different than someone who maybe only smokes, say, a 1/2 pack per day. So again, those rates are going to be useful because we can kind of do better comparisons there. And kind of go through that. Again, there probably is a dose-response relationship with this, but by looking at those rates, we can kind of make better conclusions about that. Than simply just looking kind of the crude numbers of people who died and how much they smoked, essentially, right? Okay. Oh, and I accidentally gave the answer away on this one, unfortunately. Okay, which of the following examples might represent a retrospective cohort study? So again, we were kind of mentioning these already, so let's look at why these are wrong, these cases. Cases of lung cancer assessed for prior exposures. So we're looking at people who had lung cancer, and then we're looking to see what kind of risk exposures they had previously. It's more like a case control sort of study, or a case study, and if you did not have a control to compare them to, it'd be more like a case study. Subjects randomly assigned to active varicella vaccine versus placebo, followed for chickenpox. It's a prospective study, good. And what type of study is it? It's a RCT, right? So randomized controlled trials. That would not be correct. Subjects with current angina followed for the development of myocardial infarction. That would be more like a prospective sort of cohort. So you may be looking at people with angina versus without angina, and then seeing if they develop the outcome, right? So again, you're looking at either a risk factor, you're looking at an exposure, and then you're following it forward for outcome in those cases. And then subject with skin cancer assessed for lifelong cumulative sun exposure. One that'd be kind of a hard study to do in a lot of cases, right? That wouldn't really be a retrospective cohort study. In this case, what you can see is subjects with prior radiation exposure followed for the development of these lymphoproliferative cancers, right? So you may already know if they've had the cancers or not, but you're kind of starting back at a point where they had this prior radiation exposure, kind of starting at this time point, and then even though it's retrospective, you're kind of looking forward from that time period to see if they develop these cancers or not. So it'd be a retrospective cohort study. Again, they're being divvied up based on do they have radiation exposure or not, and then going forward from there, right? So again, still retrospective. You don't go past the current point in time, because again, will we know if those patients develop cancer after this? Not unless we do the type of study, kind of a prospective study to look for that. That makes sense. Of course, I guess I goofed up the order of these slides. Anyway, okay. All right, so let's look at the physician's health study. It was a randomized, double-blind, placebo-controlled trial. It was designed to test the effects of aspirin and beta-carotene on cardiovascular disease and cancer. Participants consisted of approximately 22,000 male physicians who were 40 to 75 years of age, and the randomization of participants was done to help achieve which of the following? So why do we randomize these participants? Eliminate bias. Can we ever eliminate all bias? It's hard to do. What's external validity? The generalizability. So again, taking this information from the study, and then who can we generalize it out to? So in this case, who could we generalize it to? Men. What type of men? 40 to 75 in the U.S. who are physicians, right? Physicians typically healthier or less healthy than the average Joe? You would hope more healthy, perhaps. I've seen several very unhealthy physicians, but yeah, it means nothing, right? But we would see that this study would only apply to those kind of patient groups, right? So could I apply this to young women? Probably not. To children? Probably not, right? So external validity is not really done. The randomization does not help with that. What's internal validity? It's the strength of the study. So the actual study design itself, like how likely is it these results that we find for these particular men, how rigorous are those results, and how likely are they truly to be valid? You know, if I was goofing it up and I was, assigning patients kind of willy-nilly, even though it's supposed to be randomized, that would kind of weaken the internal validity of the study, because I could not say these results are truly valid anymore. So you can have a really good study that's really has great internal validity, but maybe not be very generalizable, and that external validity isn't very good at that point, right? But we're also going to find that the randomization helps prevent confounding by known and unknown factors, right? So the big thing we're doing here is by randomizing individuals, we're not saying it certainly helps to strengthen the internal validity, but the main point of randomization is to really try to take, because again, you can't take into account everything, but by trying to randomize them out, you're hoping these groups are going to regress to the mean, and you'll have outliers that will kind of cancel each other out in each group. And so that's the point of doing this randomization. Kind of helps with this, right? Doesn't help to achieve statistical significance. Certainly it strengthens the internal validity, but this is the main reason why we're doing these randomization procedures. Okay, does that make sense? Okay, you can kind of read through all that, but I kind of talked about those. Okay, let's see, we have a new virus being reported in the U.S. It's called gonorrhoeasyphilitis. Made it up myself. It's originating from Canada. Darn Canadians, spreading their diseases around. It's been reported to have caused 5 deaths so far. Your hospital initiates screening for all patients reporting to the ED to see if they traveled from Canada in the past 6 weeks. What type of surveillance is this? It's like passive surveillance. Yeah, it's actually a form of active surveillance, right? So this is what we do frequently. We have new cases of things like when Ebola pops up, or if we have things like Zika pop up, we will frequently ask if they've traveled to specific countries recently for every patient that comes in, not just those that come in with, say, respiratory tract infections or for whatever. We'll ask them, every single patient comes in, have you traveled to these countries in the past 6 months or 6 weeks or whatever happens to be? And it's kind of more of a form of kind of active surveillance, right? Because you were putting some effort into it. It's not just, okay, a random patient shows up and, hey, they got diagnosed with Ebola, right? You want to be more kind of active in the case. And then we talked about this, but what phenomenon might these first few deaths represent? Iceberg, right? So you're only getting the severe cases. You may have a lot of cases that may be at risk or may have the disease already, but may not have actually had any kind of symptoms at all. Usually this is going to be underreporting of actual what's going on there. You know, one day, as the climate keeps going the way it is, we might not be able to use icebergs as a good analogy anymore. Think about that one. They're all gone. You can't see them at all. No, I'm just kidding. What are some potential problems with public health attempts to eradicate diseases? We kind of talked about that in some of the earlier lectures.
Mom groups.
Mom groups. Mom groups. You care to elaborate? There's some moms in the room. You might want to be careful.
He's talking about anti-vaxxers.
Anti-vaxxers. Are there any anti-vaxxers in the room? Yeah, you're kind of on the fence still. Okay. I don't like to offend anyone. I'd probably fail at that pretty often, but okay, so that could be some public backlash to vaccines. I might not consider that here, but what are some other ones we kind of looked at? Because you can't get rid of those kind of people. They're going to find some hill to die on. Not just moms, their dads out there too who are crazy. I'm one of them. So what are some other kind of potential problems? Okay, so herd immunity, that's kind of a good thing though, but if we eradicate disease, what could we run into issues with? Yeah, so certainly there could be ecological impacts, like we talked about that desertification where all the cows were healthier and they start eating all the grass and now you have a big dust bowl. That could be one big issue there. If you imagine though, think about something like smallpox. Like we used to get smallpox vaccines pretty routinely and then we eradicated smallpox. And remember, there was like only one sample that was being stored somewhere in Europe, I believe, and then it went missing. Right, so then you worry about things like, okay, well, maybe there's a terrorist attack, and now smallpox is a big concern. That is one of those things where if you saw a case of smallpox, that's a big deal, right? Because it's something we consider to be have eradicated, and we've now lost all immunity against it for the most part. So that's one thing to consider there. Like that desertification kind of example there, the kind of ecological impacts. Because again, as we are living longer and being healthier, guess what? We're kind of ruining the earth even that much faster in a lot of cases, and going through resources and overpopulation and whatnot. So again, those are kind of indirect problems that can come about from that sort of thing. Any other ones you guys can think of? Kind of some of the bigger ones. Okay. Sometimes, what if you had kind of an overactive, like kind of screening program? Like, what if you're looking for something that's kind of like a needle in a haystack? If you're, issuing all these resources and looking for it. Yeah, so you're going to get a lot of false positives. We talked about things that have relatively low incidences. If you're screening everyone, remember that example we talked about screening all like newlyweds for HIV? Like the HIV incidence was so low in that kind of, or the prevalence was so low in that particular patient group, you're getting tons of false positives, right? And so then you have all these people who are like, you may have HIV, and then you look at your spouse and say like, what? And then you have to go all this other testing, and it's expensive, and leads to marital strife, and that's no good, right? Okay, so we talked about the difference between a risk for an outcome and a rate. Again, rate is just using what as our denominator? Mid-period population, right? It's kind of giving an average number of people who are at risk during that study period. And again, this is typically better for shorter time frames, usually for things that have a low incidence during that time frame, right? So usually less than 5% is great, less than 1% is even better, because again, that gives us a pretty good idea of what our actual risk is if were we to apply that to, say, a greater population. It was kind of the benefits there. Again, it gives us a better idea of that force of mortality rather than just looking at a pure just number of people who are at risk. Okay, which of the following would be a valid rate? So again, looking at our denominator, looking to see if this is appropriate or not. How about pregnancy in women in the U.S.? Would that be a good rate? So all women in the U.S. Probably not, right? Because again, we mentioned there are kind of women who are not of childbearing potential, so that would not necessarily be the most accurate denominator you could use in that case. Now, again, depending on what kind of data you have access to, that may be the only thing you can get an idea for, especially with like census data. And again, we're actually coming up to the 2020 census here pretty soon, which is going to be super, super important, not only politically, but also epidemiologically, because we're going to be able to get better ideas for how the population is going, what kind of trends we're going to see there. And these are our new denominators we use for a lot of those kind of large population type epidemiologic studies. Testicular cancer in the U.S. population. No, why? Half the population doesn't have testicles, so they can't really have testicular cancer, right? How about Republican voting in Floridians less than 45 years old? I'm an odd one. Just think. Try not to get too political with these things, but. Good, absolutely. So people less than 18, guess what? They can't vote. No, they cannot do that. So again, that would be losing a subset. That would not be an appropriate denominator for everyone under 45 years of age. Certainly you could do like say greater than 45 because all those people would be eligible to vote. Also, you have to consider though like who else cannot vote. Criminals, yeah. So if you're like convicted of a felony, you may not vote anymore. You've kind of forfeited that right. So that's another thing you may need to consider as well. Like what kind of proportion of those people? Probably small, but you'd hope at least. How about RSV in children less than 1 year of age? That would probably be pretty good, right? It's not something we routinely vaccinate for. This is something that could definitely occur. So I'd say, yeah, kids less than 1 year of age, they tend to be at risk for that. Now, if you were to look older than that, you may not have a great rate at that point because, again, RSV is really kind of a disease of really kind of the young kids. They're the ones that are going to get sick in a lot of cases. Older kids, not so much, right? So that would be probably a good rate there. Yes, ma'am.
I'm sorry, what did you say the advantages of rate were?
So the advantages of rate is you get a better idea for kind of that force of mortality or that force of that actual event occurring. So you can see things like, well, did it occur the event occur very early on? Was it very steady throughout that whole period, or was it kind of at the end? Because that will adjust your rate a little bit. And then again, they're good for comparisons between different things. We looked at age-adjusted death rates. It's a pretty common thing that we end up using. But that's one of the benefits there. You're not just looking at a static number of like these are the people that had the event. This is the people at risk. You're more looking at that. Well, how did it actually occur over time? Any questions I can answer for you? Was that helpful? I hope. Our test is next Wednesday, I believe. So you have lots of time. You guys can just like think about it, perseverate on it. You can just come up with all kinds of good questions, and then email me or come to my office. We can just talk about it. I think sometimes like just talking one-to-one that really helps out with understanding a lot of this stuff. So again, any questions, please let me know. Anything else in the meantime? Did you guys like the journal clubs? Is that?
Yeah.
I like feedback on that stuff, so let me know if you guys thought that was helpful or valuable, or
My course evals.
oh, did you already finish all those? Oh, I heard there were some server issues with the course evals.
We all got deleted.
I said mine are pretty easy because you only need like 2 letters for mine. It's like an F and something else. So I did shorten up this. If you notice, I think the actual video length is probably a good deal shorter than what we actually had allotted for the actual number of class sessions. So I did try to tighten this up a little bit, quite a bit actually. So I think, and feedback about the online portion of it will be very valuable. This is the first time we're doing it primarily online. So anything else? That's it, I think. Thank you so much. Have a good day.